Niranjan Chavan, a very popular figure amongst all the Foxians. He's a great orator, a great teacher, and today he'll be talking on fibroids, a very common finding on the ultrasound for the gynecologist, and the role of Ulipristal in the management of fibroid. Over to you, sir.
Thank you for that kind introduction, and I would like to thank the Indore organizing committee, Dr. Kavita Bapat, Asha Bakshi and Archana Baser to invite me to talk on this topic. Well, as you are aware, Ulipristal in fibroid management, we had it been used for a long time, and there was a delay in its use for about during the COVID time. And I want to go back and just refresh you what happened and how things can change in the conservative management of fibroids. Today, even if I make 10 women stand in front of me, out of that 4 women have fibroids, and they are ranging from the age of adolescent girl, even postmenopausal, and the first thing they come to me and tell, Sahab, mera theli nikal do. And that is not the solution. If I start removing out of 10, 4 women's uteruses, it's unethical. It's not right. And there are things which are changing in the perspective in science, and there are things which are happening which are beneficial. So let me just start with some introduction of uterine fibroid. We all know it's basically an intramuscular hypertrophy. There is hyperplasia of the cells. It's a smooth muscle and it undergoes changes. You can have single fibroid, multiple fibroids. Place of fibroids can be different, as we are all aware: subserous, submucous, intramural, wandering fibroid, cervical fibroid, broad ligament fibroid. It can go anywhere, and because of the enlargement, you have certain patients who have such big fibroids. We have seen in our practice 24, 26, they don't have any pain at all. And there are small tiny fibroids of 2 centimeter and 3 centimeter, and you find this patient having anemia of 6 grams hemoglobin. So it is not totally related to the size, it is not related to the place where it is. We are still trying to understand. It's all the situation which we find in our women. It's only on an ultrasound when they come, or they have something, maybe a query cyst or query ovarian tumor, something like that. And actually when we do a laparoscopy or you try to assess them, then you find out exactly what is the fibroid. But these are the risk factors where, if it's an unmarried woman, if she is not having deliveries, she is nullipara, early marriage, and of course family history is there. Hypertension, diabetes is also to be found as one of the factors. So commonly, as I said, you have about out of 10, 2 to 3 patients who are having this fibroid, and I have seen that as the age increases, the incidence of fibroid increases, especially in the reproductive age. I have seen patients coming with endometriosis even after having 3 normal deliveries or a cesarean section. Like, endometriosis was only defined for a particular age group, but fibroid, it just goes on increasing, and when it reaches in the premenopausal woman, the range of fibroid, out of 10 women, you can have 7 to 6 or 5 women having a fibroid. This is a wonderful chart I would like to share with you, and it tells you the percentage. So it is not only in the adolescent or the reproductive age, but it is more nearer the menopausal, perimenopausal age, and that's where you can have these fibroids coming at any age group. These are the various factors you see that can cause fibroid. So it is a hyperestrogenic stage, it is a genetic factor, it is something related to inflammatory changes, and you have epigenetics, extracellular matrix component, and all of these form a uterine fibroid, and it is still unexplained. Now let us understand the current treatment. This slide is beautifully showing left and the right hand side. So if a woman who comes to you with a fibroid and she is desirous of fertility, what options are available to us? It depends upon her symptomatology. If she's asymptomatic, you can just try to find out what is the size, the shape, the site of the fibroid and go ahead with it, the treatment. If she is bleeding profusely, there are medicines which are available. And the time tested one is to give progesterone in the second half or put her on OC pills for 3 cycles or give her GnRH agonist. And of course, the size of the fibroid, if it is more than 6 centimeters, 5 centimeters, there is an option of myomectomy. And it doesn't end here. I have seen patients again coming with a fibroid after 1.5 years, 2 years. I have operated on a patient coming from Dubai. Her husband is 80 years old. He's a sheikh there. And in their situation, they do not want the uterus to be removed. I have done 3 times the myomectomy and it just goes on and on. So myomectomy is also a certain individual. I don't know, some women have extra estrogen and there are other factors, as I said before, and it comes again and again. And of course, those patients who are not desiring fertility and they have this pressure and bleeding symptoms, we need to understand to still, conservatively treat them. I have been treating a woman from 2013. We are right now in 2022. When she had come to me, right now she's 52 years of age. She is a wife of a security head who is the head of our municipal corporations. He's in the post of DMC, and the first thing, she had one intramural fibroid, one another fibroid. The first fear they get is, I want to just remove. I said, no, just wait. It is just a psychology, and they get stressed out. They get really stressed out. What is this growth which is there, abnormal in my body, is still doing there? I said, just calm down, just take medicines, continue your management, and let's see. So we just do an ultrasound every 6 months, every once a year, and she religiously comes. And sometimes the fibroid grows, sometimes it reduces in size. And there I tried also Ulipristal in that time. It made a lot of difference. I'll come back to in my talk further. But those who are not desirable of pregnancy and they are completely fine, they have that knowledge that they don't want to undergo all these things, you have a hysterectomy choice. So there are limitations which are there, as I said, because everyone is not able to undergo a hysterectomy, a laparoscopy. The second thing, they come, वो laser है क्या आपके पास, laser है क्या, वो मुझे laser से निकालना है. Now how do I explain that there is nothing like laser to be used in a hysterectomy? It's not like Nd:YAG laser and all that. So they have that. वो दूसरा हमने सुना है वो MRI की मशीन है, वो कम होता है. And then we have incidences which have occurred in the other hospitals, unfortunate incidences where they have got issues of problems, and of course the cost is like 75,000 to 50,000 per sitting in those corporate hospitals. So, we are trying to get one MRI, and we have literally got one MRI now with reducing the fibroid. That is also a technique which has come. So there are all interventions which are available, medical line of treatment, and it is still limited with symptoms. GnRH agonists are licensed, but only for a short-term therapy. You give it for 3 shots, 4 shots, and they spend about, say, every like 2.5 to 3,000 per injection, and then again it comes back once you stop. It will cause amenorrhea. So there are a lot of things which are there. And at the end of the day, they don't want to lose that amount. They want something miracle, some wand which you have. It's like just you have and the fibroid goes away. I hope that day comes, but till the time we have these limitations. And then we had this Ulipristal. We know it is a selective progesterone receptor modulator. It modulates the progesterone receptor activity. It has a pro-apoptotic and anti-proliferative effect on the fibroid cells. There are so many things which we have gone through. The mode of action is accordingly, you see that they have the interaction with co-activators and co-repressors. So in this way, the gene transcription is either inhibited or activated. This means that the stimulating or inhibiting effect of SPRM is dependent on its chemical structure, and that's what this slide explains us. So as I said, it inhibits the proliferation of the extracellular matrix, that is apoptosis induction, and also it helps in reduction of the fibroid. There is inhibition or delay of ovulation when you have a partially reduced LH and FSH, and of course that helps in reduction of the bleeding. You have anovulatory cycles in some, and that also can significantly cause amenorrhea, and that's how it controls the bleeding. Well, it's rapidly absorbed. It can, the terminal half-life is up till 38 hours. It's highly bounded molecule to the plasma proteins, and its metabolism is mediated through cytochrome P450 3A4 isoform. The main route of elimination is through the excretions which we have through the urine and feces. The drug has been tried and it has been used in fibroids in premenopausal women for whom the surgical procedure, including the uterine fibroid embolization, are not appropriate or have not worked. And the drug, however, must not be used for controlling only the symptoms of uterine fibroid while awaiting surgical treatment. Now, the DCGI has approved it. The treatment consists of one tablet which is given 5 milligram. It has to be taken once a day, and then you can give it for a period of 3 months each, and the tablet may be taken with or without food. Contraindications are very minor, little hypersensitivity. Of course, in pregnancy and breastfeeding it is not to be given. There is some amount of bleeding which can occur. We don't know what is the cause of it. And of course, cancers. You don't give this drug in cancers and liver problems. Now I want to take you back in 2008 and 2009. Briefly, I will go through the journey of how this started when this molecule was introduced. And there are European trial and there is an American trial, and all this was followed up. And I have met Jack's donors. I'm sure Dr. Sanjay Gupte sir, we have met him as a very big pioneer in this field, and this was carried out a trial in the East European country. Right now there is a war going on. We don't know what will be the situation, but 36 European countries were involved, and there were a good amount of patients. And the summary which they came up with this Pearl 1 trial, that it effectively controls the excessive bleeding and pain due to fibroids, and it reduces the fibroid size. So this is what they found, and it got published in 2012. The journey started in 2009. Then we had the Pearl 2 trial. They wanted to further increase the number of the patients. Initially it was with placebo and only Ulipristal on one arm, and this was, along with that, they had oral as well as injections being given. So the patient was not able to understand whether he has received an intramuscular injection which is causing the reduction, or whether it is an oral tablet of Ulipristal, or also the other arm the patient was given a placebo of an oral tablet. So this was done, and they found that it is not inferior to leuprorelin. They compared that also with GnRH agonist, and they found that it is helping in the reduction of uterine bleeding and fibroid size, but has superior tolerability, a lower incidence of adverse side effects. This was also published in the New England Journal. Then we had the extended Pearl 1 trial. So it was not only remaining for 3 months, it was further extended to the next 3 months, then a gap of 1 month, then the next 3 months, then a gap of 1 month, and then a next 3 months. So this was an extended trial. This was 3 months course, and they had given 5 milligram. They had also given 10 milligram once a daily, and they found that it restores the QOL over the long term in many women with symptomatic fibroids. This was the Pearl 3 extension study group by the same author. This was published in 2014. Then we had the Pearl 4 trial, and this was also published in Fertility, Sterility in February 2015. It was very well tolerated by 5 milligram as well as 10 milligram, and it was superior to the placebo in rate of and the time to amenorrhea in women who had symptomatic uterine leiomyomas. So this is Pearl 1, Pearl 2, Pearl 3, Pearl 4 trials, which was carried out by Jacques Dones in the East European countries, and it was with placebo, a double arm study which was done. So the summary, if you have, the first trial said that it normalizes the blood loss. The second one, it helps to have a faster and more consistent control of bleeding as compared to GnRH agonist, and had more favorable side effects profile. The third one was also helpful in decreasing the fibroid volume, and also was effective when it was an extended arm which was used for 3 months 3 times, and it was much better than norethistone which was being also given. And the fourth one was they had 4 cycles, and the findings had little difference between 5 and 10 milligram, and there was hardly that much of change in the menstruation or the fibroid volume when you compared. So basically it was then decided to be an effective alternative treatment option, a long-term treatment, and that's where we started using Ulipristal in a very big way. And it was much more effective in reducing the pain, the fibroid volume, and the control of menstruation. More than 95% of the patients were there, and it was verified by the PBAC scores, and that is how the quality of life was much better in the Pearl studies. The higher dose of 10 milligram Ulipristal acetate is, however, not to be found significantly superior to a 5 milligram per day, and it was hence not recommended to prescribe 10 milligram per day at that time. Now there is something like Premia study. I came in through the literature also, and they had a world data. This was about 1473 patients they treated with Ulipristal. This was carried out by Fernandez, published in the European Journal, and they concluded that the physician's assessment of the symptomatic change indicated that 60.1% of patients were much improved or very much improved at 3 months, and the patient's perception of improvement was highest immediately after Ulipristal acetate, and with 87.8% of patients greatly or somewhat improved. So this is what was the Premia trial which was done. Then on transatlantic side in United States and in Northern America, they had Venus 1 and Venus 2, which was carried out by Andres, and it was consistently similar. This was also done in 2017. They found that both the doses of Ulipristal acetate were superior to the placebos in the proportion of women achieving amenorrhea and the time to amenorrhea, and it was well tolerated. Numerically greater responses was seen, and its efficacy was observed with Ulipristal acetate 10 milligram versus 5 milligram, and the safety profiles were similar. Now this is also an original paper which I wanted to include in my talk, and this was done by Sangam Jha, Naz Ahmed. They are from All India Institute of Medical Sciences, Patna. This paper got published just recently in 2021. 79% of women, they achieved amenorrhea for 35 consecutive days during the first treatment cycle, and that was a huge big number, with a median time to amenorrhea being 7 days to 5 days during the first and the second treatment cycle. There was a reduction of the fibroid volume, 32% and 52% of the first and the second treatment cycle, and they also monitored the serum estradiol, and it remained at the mid-follicular phase. There was no serious drug emergent side effect of liver injury, and that is how this paper was accepted. One more article I went through just recently in January 2022, it got published, where Ulipristal as a progesterone receptor modulator helped not only in fibroids, but they have this wonderful study on breast cell proliferation, and the women selected were between 18 to 39 years of age. They randomized 1:1 Ulipristal 10 milligram daily or a combination of oral contraceptive for 84 days, and they also underwent a biopsy. They had a breast MRI being done as a baseline, and at the end of the study they further did a further MRI, and they found that yes, there was certain amount of breast terminal duct lobular unit cells were evaluated, and it was associated with major decrease in this immunohistochemical molecule Ki67 and BPE. So this was also one thing which I found on the literature, that it is helpful in the breast cell proliferation. Now I want to take you to the algorithms of fibroid. We have the FIGO classification. It is the older one which is still being continued. We have different types of fibroid, type 0, which are there. You can see them. It is an intramural, it is mucous fibroid. You can see through hysteroscope. You can further manage it with hysteroscopy and remove the fibroid. If it is larger, you can have to do 2 sittings, and we can complete the whole procedure by removal of this fibroid. The type 1 is less than 3 centimeter and more than 3 centimeter. Yes, this also can be tackled with hysteroscopic myomectomy. And if it is more than 3 centimeter, you can still give medical therapy, which is available with us. And if it gets reduced, then she can undergo hysteroscopic myomectomy. So basically, Ulipristal now comes into the picture, where you can give it if it is a uterine fibroid less than 3 centimeter with anemia, or more than 3 centimeter with or without anemia. And this is what is an expert opinion and emerging drugs article which has come up. So we have these 2 types of fibroid, and then further multiple fibroids are available. We find intramural, we find subserous fibroids, desirous of pregnancy on one hand, not desirous of pregnancy on another hand. And there is the role of Ulipristal, which can be there, given for at least 2 courses for a period of 3 months, and that is quite helpful in those patients who are absolutely desirous of fertility. And this is an option we can give, because it causes amenorrhea, it helps in reducing the pain, it helps in reducing the bleeding, and of course then maybe after some time you can go ahead and try to have a conception being there. Naturally also they conceive, and if she is desirous, and if it is distorted myoma, we can undergo a myomectomy. Of course, those who are not desirous of pregnancy, this is what can be given, and these trials are said you can give at least 4 courses as per the Pearl trials which are there available, extended one, and it helps in reducing the volume, it helps in reducing the bleeding, it helps in reducing the size, and she is much more better. If not still responsive, then she has an option of going for a myomectomy, and that is what we can do. So we have type 2 and 5 myomas. Ulipristal can be recommended in infertile women who are trying to conceive. You can give a shorter duration, and of course with multiple myomas of more than 2 or of different types, you can give a 2 courses of 3 months. And then for premenopausal women, you can give 4 courses of 3 months, so that it is much better off, and it helps significantly improvement as she advances. Well, now we come to the safety concerns, and we all are aware that there were issues about the liver associations affecting because of the Ulipristal, and there were incidences which were reported, especially on the European Medicine Agency Pharmacovigilance Risk Assessment. And it was noted by the reviewers that there was only 1 case of hepatitis, which was probably a suspected drug reaction because of use of Ulipristal, and 1 case had liver fibrosis and 1 was fatty liver non-alcoholic, and of course there were other 8 cases with abnormal liver functions, and this was then decided to be linked with UPA. Worldwide, there were then reports of liver damages in other 5 patients, and further increase in the cases were there, and therefore there was a certain amount of not using Ulipristal during that time. Now this figure which you see in front of you, this is of the latest 2021. We had COVID, as you are aware, during 2021, and just now we are coming out of COVID, and that is where the articles got published in November 2017 and May 2018, and that was how it was not to be used by by us and to be given to the patients. And that was then further assessment was there between these 3 years, and then we had this from March 2020 to September 2020, an Article 31 procedure by the PRAC. So Ulipristal was now kept on hold, but then they compared with other drugs, and this chart is a wonderful study which I want to show you. This is the drugs which you see in the center. These are azathioprine, infliximab, and you can find diclofenac, atorvastatin, and there is a risk of liver amount of injury being there, and you can find even in diclofenac, it is there. And 1 in 9,890 patients or 11 in 1 lakh patients can be there suffering with Ulipristal and diclofenac. So this is what is similarity you can find with even antibiotics, anti-inflammatory. Why only this molecule? So the DCGI then revised the indication of Ulipristal acetate. This absolutely had removed of this, and now it can be freely absolutely used, but there are certain conditions which have been laid down, and it has to be used only in premenopausal or in reproductive age, and it has to be given appropriately. But you need to work up with the liver function test. You have to do the liver function test. After 3 months again you need to do a liver function test, and it has been clearly indicated that yes, if you do this follow up properly and the patient doesn't have any increase in the liver function test, you can continue to give it for further 3 more cycles. And that is what has come up. This is what is the risk mitigation they have given, and you do not have to be worried about the increase in the ALT or AST. And there are certain formulas which have come up, and it can be done every 3 months and every 15 days. So all this has to be explained. There are certain signs which are there. You have to understand that the patient might feel tiredness. There could be certain like jaundice which comes up, but it's very, very rare, and it can come 1 in 1 lakh or 1 in 9,890 as you have in diclofenac. But 1 in 1 lakh patient is nothing big deal. That is what you have to understand. And in fact, if you have such patient, where I think it is very, very rare, you need a hepatologist to be referred, and then you need to perform the further testing to be done 2 and 4 weeks after the cessation of treatment. So basically now we are very sure of what we are going to do. We are having a proper plan to go ahead to give this drug for 3 months, and then further extension of 3 months, and then further extension of 3 months, and further extension of 3 months, especially in the perimenopausal and in the reproductive age. You can give a shorter duration, and it has to be absolutely monitored properly. Just do a liver function test. If you do an ultrasound after 3 months or 6 months, you will find that there is reduction, there is amenorrhea, there is reduction in the bleeding. The correction of anemia has been done by given oral iron supplementation, and it's very well tolerated drug, and it can be given in such cases also where there is heavy bleeding. So to summarize, I would like to say that yes, Ulipristal is not the new kid in the block. It is the kid which is going to see this decade as an enterprising drug, and it is going to solve many hysterectomies to be reduced. It is going to reduce myomectomies over a period of time, and surely this is a relieving factor for us. I remember letrozole was also banned when letrozole had some issues, and then now we find letrozole left, right, center being used, because that is how the mind works, and that is how the literature comes. And now there is an efficacy you find. Now there is a safety you can find. We are the custodians of women's health. We want them to be given the best option. Surgery is not the only option. And today I find this 52-year-old woman, she is menopausal now for 6 months. She tells and comes back to me every time, "Sir, you saved a surgery for me," because surgery is not a very easy thing. You go ahead to do a surgery, it takes at least 3 months for the patient to recover back. I'm finishing 1 minute time. So this is a very important message I want to give you. Do not be hesitant. Start Ulipristal. Start doing liver function test before you start. And repeat it again after 15 days. Repeat it again after 3 months. See the benefit. She's going to have a very good improvement in her whole lifestyle. And what you require apart from drugs, psychological help. Talk to them. be nice to them, and I'm sure that is how you will be able to reduce those unwanted surgeries which are not to be done in such cases. Thank you so much.
Thank you, Dr. Chavan, for that lovely deliberation. As you rightly said, 3 out of 4 will have a fibroid on an ultrasound report, and hysterectomy sometimes will be, we'll find it unethical doing a hysterectomy for such patients, and the treatment will especially depend upon whether she wants a fertility conservation or if the bleeding is a problem, but you also always have to counsel her regarding the recurrence. And as sir rightly said, if the fibroid size is less than 3 centimeter and she has anemia, you definitely should go for it. If it's more than 3, even if there is no anemia, you can go for it. As more studies are pouring in, the safety profile we are assuring, getting assured of the safety profile, but we should still keep a watch over her liver test to be repeated maybe twice a month in the first month, and then after 3 months. Even after the treatment, one should carry on with the liver profile. Thank you so much.
I think you summarized wonderfully. Thank you so much. I think there is no questions now.
I'm so sorry, we are short of time. Our next speaker is ready right here. We can have